Hi,
Okay,
welcome
thank
to
you.
today's Telehealth Secrets webinar. You can't see me, my name is Anne, but I want to give you a quick housekeeping things. So there, you should have a questions chat box. If you have questions, go ahead and put those in there. We're going to do our best to get through all of them today, but I know there's going to be a lot of questions, so I'm going to apologize ahead of time if we don't get to them. Also, just a quick show of hands. If you're having any audio problems, if you can hear us, I should say. So you should have a hand raising thing. So if I can just get a show of hands. Okay, thank you, Nancy, Rebecca, Robin. Okay, great. And then, so Thursdays, we've been doing our basic VSee clinic training on onboarding sessions. So we're going to be going back to that next Thursday if you have questions about using VSee. And we'll also have our next telehealth secrets webinar is going to be on Wednesday, May 13th, focused on getting started in telepsychiatry if you have questions about that. And let me go ahead and pass the time then to Milton now.
Great. Thank you so much, everyone. I really appreciate it. So my name is Milton Chen. I'm the CEO of VSee. And today we have a special treat with you. We have Mike Enos, who's going to teach you, like, I think everything you would like the whole industry has been struggling with in there. So Mike is a medical coding expert. And what's interesting is, so Mike and his mom are a mother-son business team and doing phenomenally well. And what's maybe even more interesting is that Mike is also a triplet. So he has an identical twin brother in the computer industry and a fraternal twin sister in radiology. So it's a pretty exciting family. So he's also currently working to figure out how to just, this sort of homeschooling duties, with with everyone staying at home and so on. So Mike, thank you so much for joining us.
No problem. All right, I'm going to change the screen here. All right.
Perfect. So
you should be able to see the title screen here is Telemedicine and COVID-19. Thank you very much for that nice introduction. My name is Mike Enos. I'm a coding consultant and instructor based in beautiful Rhode Island. So we're going to do a little presentation today on telemedicine during the COVID-19 public health emergency. The agenda for these presentation, the slides will be available. I believe they're a handout right there for you, so you can refer to any information. So if you did miss anything, handouts are right there for you to refer to. We're going to go over defining telehealth. First of all, what is it? We're going to clarify the waivers that CMS recently announced that greatly expanded access to these services. We're going to talk about the CPT codes that are applicable. So what can you bill via telehealth? We're going to talk about the different technology requirements because telehealth is not just one service, it's a category of services. I'm going to talk about how you choose the right code, and then we'll close out with a couple slides on modifiers in telemedicine and place of service when you're billing telemedicine claims to make sure you get the maximum reimbursements. So first off, what is telehealth and telemedicine? There's a little bit of confusion because these terms are often used interchangeably, even by different insurances. They might mean different things, but they're both broad terms. So telehealth refers to the exchange of medical information from one site to another using electronic communication. And telemedicine is the practice of medicine using technology to deliver care at a distance. Both of these terms are very similar in definition. So the tricky thing is understanding that both of these are sort of umbrella terms, and neither of these terms mean one particular type of service. Instead, they describe a broad category in which there are individual specific types of telehealth. So people get confused when, for example, CMS says they're going to broaden access to telehealth regardless of the technology used. They think that that means regardless of the technology, you can bill a particular code. That's not the case. You still have to bill the code according to the technology that you use. I'll have a slide coming up here that's going to break it down for you, which technology means which code. Now, it's important to know that reimbursement will be allowed for telehealth covered CPT codes regardless of the diagnosis. So a lot of people think that these codes are only covered if the diagnosis is COVID-19 or screen or diagnosis or treatment of COVID-19. That's not the case. These codes that we're going to talk about today are covered regardless of diagnosis. On March 17th, they announced that there were 101 CPT codes that were eligible for telehealth payment. These include a number of codes, but I bolded the ones on this slide that you can see: office or outpatient evaluation management services, which is your typical office visit with a provider; subsequent nursing facility or hospital care services; psychotherapy services; health and behavioral assessment intervention services; end-stage renal disease services. Note, however, that preventive medicine visits are not covered for any age. And when I say that, that means the annual physical or a well visit exam. Medicare annual wellness visits, however, actually do qualify. But for most commercial insurances, you have that yearly physical. That's not covered during telehealth. They then expanded the codes to add 80 additional services on March 30th, which included a number of services, including the ones you see on this slide. I'm just going to breeze through this, but again, you can refer to this in the handout. You see here bolded our initial nursing facility and nursing facility discharge services, all observation care services. Home visits for new patients or established patients can now be covered via telehealth, and a number of other services, assisted living check-in services. Also cognitive assessments, group psychotherapy services, and psychological or neuropsychological testing services are all applicable now to bill via telehealth. Note that not included in this list was any services typically furnished by physical therapists, occupational therapists, or speech language therapists, which is unusual because those provider types are specified as eligible, but the codes themselves were not. I honestly think that might have been an oversight on CMS's part, so I wouldn't be surprised to see that change in the near future. This slide gives you a breakdown of the types of telehealth services, the codes for each, and briefly what they are according to the technology and the type of service. So you can see the first column here, or sorry, the first row here is the Medicare telehealth visit. And this is your typical, what would be an office visit face-to-face, but just simply done via telehealth. So you can see the code range for that is 99201 to 99215. These are for new or established patients. And to describe that, it's a visit with a provider using real-time audio and video telecommunication systems between a provider and a patient. So this could be something like using FaceTime on an iPhone or Google Hangouts on a laptop or Chromebook, a tablet, regardless of the device, as long as it's real-time, meaning as I'm talking, you're listening, not something recorded and viewed later, real-time audio and video. In that case, you can bill 99201 to 99215. Other codes are the virtual check-in, which is a brief technology-based check-in for Medicare, G2012 and G2010, depending on whether it's real-time or if it's remote evaluation of a previously recorded video submitted by a patient. That'd be G2012 or G2010. You have online evaluations, also called e-visits, depending on if it's a provider or a non-clinician. If it's a provider, your codes are going to be 99421 to 99423. If it's a non-provider, so anybody who couldn't bill an E&M visit, so 99421 to 423 would be an MD, DO, PA, NP, anybody who could bill an office visit. G0261 is non-physicians. And those are for communication between a provider and a patient through an online patient portal, not live. So this could be something like an email or a secure patient communication. And those services are billed based on the time spent cumulatively over a 7-day period. Then the last row here is for telephone only services. When I say telephone only, I mean audio only evaluations. You have two different ranges. Again, they delineate physicians versus non-physicians, and it's based on time spent. So your codes are 99441 to 99443 and 98966 to 98968. That last row was not covered by CMS previously. Previously, that was a commercial insurance only, but at the behest of the American Medical Association, at least during this public health emergency, CMS on an interim basis has added those codes to their physician's fee schedule. You can find that on the March 30th interim final rule. So this is the summary of telemedicine services. I want to take a look at that first row. This is the EM telehealth visit. So these are the typical what you would do for a face-to-face visit. You go to your doctor, you go over your history, you talk about your problems, they do a brief exam, there's an assessment, and you typically bill one of these codes. You have 99201 to 99215, depending on the level of service. Now, typically, when you're billing one of these services, it's going to be a higher level depending on the extent of the service. So a more complex history, a more intensive exam, more complex medical decision-making. So you can see on this chart, I have a column for each of those key components. However, there's another thing that you can consider, and that's the time, okay? So on this chart, I put in blue the time. They actually recently revised the time components for these telehealth visits, and I think it's a great thing. So let's take a quick look at how time can be used to choose the right code, even if there is no exam, because it's difficult to do an exam in this type of format. So CMS is using different time thresholds now during the public health emergency, and so it's going to be important when you have one of these telehealth visits to document the total time spent, including the quote-unquote face-to-face time, which I guess could just be FaceTime. It's the time you spent on the call, and the non-face-to-face time, so time spent before the call or after the call, preparing to do that call with the patient, charting the note, all that sort of stuff should be included in the time, as long as it's time personally spent by the provider. If you do that, you're going to use the time thresholds you see here on the right. So the codes are on the left, 99201 to 99215. In the middle column is the typical CBT time, and on the right is going to be what CMS is now recommending we use. It's slightly higher than what's typical, but the difference is it includes pre and post procedural time, whereas usually only the intra-service time counts, only the time you spend face-to-face with the patient counts. The time spent after they leave charting the note doesn't count. Now that time does count, but the time thresholds have gone up a little bit. So CMS is allowing on an interim basis, they will apply these rules to all outpatient E&M telehealth visits during the public health emergency. Specifically, they are removing any requirements for the history and exam components. So you still have to have medical decision-making, but there's no history or exam requirements. Instead, the clinician can use either the medical decision-making component, so how complex the decision-making is for this patient, or the time alone to choose the code. And it includes all the time associated with the evaluation management service on the day of the encounter. So that's actually in line with changes that are coming next year. If you've heard that in 2021, there are major changes coming to the evaluation management codes, these changes are in line with those. Again, this is applicable to the 99201 to 99215, the office visit codes, based on the amount of time spent, as long as it's time personally spent by the provider. For more information, if you want to look that up, you can look up the CMS interim final rule published on the cms.gov website under section W, level of selection of office or outpatient E&M service when furnished via Medicare Telehealth. It's on page 135 to 137 of the interim final rule that went into effect on March 30th. Now, just to close out with a couple of tidbits on modifiers and place of service. So initially, Medicare was requiring a GT modifier. Commercial insurance is requiring a 95 modifier, and people were confused and they meant the same thing. So on March 30th, they clarified that during the public health emergency, you're allowed to use modifier 95, regardless of whether it's Medicare. So typically Medicare wouldn't have accepted that, now they will. Modifier 95 just tells the insurance, the service that I'm billing you for was not face-to-face, but was furnished via real-time audio-video technology. Now regarding the place of service, this is another area where a lot of people have some confusion. As of March 30th, CMS updated. Initially, they were telling people to use place of service 2 on telehealth claims, which is place of service telehealth. Now they're telling you to use place of service 11 for office, or whatever the place of service typically would be for the service. So if it was a nursing home, typically bill it as nursing home. So whatever the typical place of service would be, it's important that you do that because now they said they will pay you at the same rate, which would be 100% reimbursement. If you bill it using place of service 2, they're going to pay it still, but they may reimburse you at a lower rate, 80%, which is typically what they would pay for a telehealth service. So make sure going forward that you're billing these telehealth claims with the modifier 95 and with the place of service, whatever you typically would do. So place of service 11 for office visits. They also announced some changes related to cost sharing. So typically when you do these E&M visits, a lot of times patients might have a deductible, might have a copay, and the administration wanted to make sure that people didn't feel hindered by that. They wanted to incentivize people to call and use telehealth services. So cost sharing does not apply for COVID-19 related services, which is any service furnished between March 18th and for the duration of the public health emergency that either result in an order for a COVID-19 test. They're related to furnishing treatment or evaluation for an individual for the purposes of determining the need for such a test, or are in any of the following categories of evaluation management codes. First and foremost, there you see office and outpatient services. Now, to do this, you're going to bill this with modifier CS. So for services furnished on March 18th and throughout the public health emergency, you can furnish services that are related to, like I said, COVID-19 testing, diagnosis, treatment, using modifier CS on the applicable claim line to identify that this service is not subject to cost sharing. It is subject to the cost sharing waiver, and as a result, CMS will pay 100% instead of maybe the patient hasn't met their deductible yet. They would typically pay 0 and you would have to bill the patient. They don't want that. So professional claims, if you submit this claim with modifier CS, you'll get 100% payment. So key takeaways from these slides. Starting March 1st and for the duration of the public health emergency, you can now bill telehealth services for more patients than ever before. They're billed and paid just the same as they would be for a typical office visit, using the same code, using the same place of service. You're just going to use the modifier 95. The patient doesn't have to be in a rural area. They don't have to be in a physician shortage area like they typically would to have these services covered. During the public health emergency, they want to prevent the possible transmission, spread, or exposure to the virus. So they're making this available to every patient, even in urban areas where you typically would have great access to care. Again, the goal is to prevent them from having to go to a hospital if they don't need to. And again, typically to get telehealth, they would have to travel to a nearby clinic or hospital that would have an approved setup to use this. During the public health emergency, they can do these services even in their own home, and they can use any technology that is available to communicate with the provider, including a smartphone, tablet, laptop, and any number of softwares, as long as it's not public facing. So they can use GoToMeeting, they could use VSee, they could use Zoom, they could use FaceTime, Apple FaceTime. What you can't do is use a public facing software. So you can't use Twitch or YouTube Live or TikTok or Instagram. Those are public facing, you can't do that. And these are not, so they're allowing greater flexibility for cost sharing. Again, if it's related to COVID-19 testing, diagnosis, or treatment, you use that modifier CS to get 100% reimbursement, cost sharing waiver. These services are now billable to new patients. Typically, you would have to have an established relationship to bill these services. That's no longer the case. Due to the public health emergency, they will pay these services even for new patients. The place of service would be reported just the same as it normally would. So for an office service, use the place of service office to get 100% reimbursement. Modifier 95 shows that the claim was furnished remotely using real-time video and audio technology. And modifier CS would be added to any Medicare claims to identify a service that is subject to the cost-sharing waiver for COVID-19 testing-related service and not charge Medicare patients for any coinsurance or deductible for those services. So I hope that was a somewhat understandable breakdown of a pretty complex topic. Again, these are new services. Well, they actually aren't new, but they're broadly available now due to the public health emergency. There's different categories of them depending on the technology that you're using. But again, the key things are how you bill it to make sure you're not only getting paid, but getting paid the most you can. For more information, you can go to coronavirus.gov. You can check the cms.gov website for a number of fact sheets and frequently asked questions. The AMA has a number of interesting resources on their website that they've made free. Usually CPT Assistant is a subscription service that they offer. They actually published a free edition with guidance on billing services related to COVID-19. And again, my name is Mike Enos. I'm a consultant on this. So if you have any questions, there's my information there. We also have time here for some questions and answers now for you.
Mike, thank you so much. That was like really, really informative. Really appreciate it.
Sure.
I guess I know from like our user, there's a lot of confusion into like, what place of service should I be using for my telehealth service, right? Your people supposed to use the place of service 2 for telehealth. I'm also hearing like, you can treat it like a normal place of service. Can you just expand on a little bit?
Well, the reason why there's so much confusion about that is because at the beginning of this public health emergency, CMS was telling everybody to use place of service 2, and then they changed direction on that halfway through March, or maybe at the end of March. They said, now we want you to use whatever the normal place of service would be. So that's kind of their fault that they put out conflicting information. I would hope that, and I'm not sure that they're going to do this, but I would hope that they're going to automatically reprocess any claims that were billed using the place of service 2 and update them. But the most important thing that I could tell people who are currently wondering how to bill this going forward, make sure you're using the place of service that you typically would for these services. So if it's in your office typically, and you're doing a telehealth service, don't use place of service 2, use place of service 11 to make sure you get 100% reimbursement. If you use place of service 2, you might get paid, but you might get paid less.
Okay, got it. That's definitely really helpful in there, because I think I'm conscious a lot of people making that mistake in there. Yeah. Another question, like we hear this, like the modifier for GT or 95 bouncing around, like, like, so in terms when they putting the modifier for telehealth claims, like, just what's the difference between the GT and 95, and like when do we use the new modifier CS?
Yeah, so GT and 95 are almost the same modifier. This is something that CMS does sometimes and drives me crazy. The AMA will come out with a modifier like modifier 95, and the AMA publishes CPT and they define clinical practice. And they came out with modifier 95 that says, service rendered via real-time audio video. And then Medicare will say, we're not going to pay that. We're going to come up with our own G codes and our own G modifiers just for us. And even though it means almost the exact same thing, they've done this a number of times. So that's why there's confusion. So G codes and G modifiers are for Medicare, and then 95 modifiers for commercial insurances. The good news is, at the behest of the AMA, on an interim basis at least, Medicare will pay for modifier 95. So now it's just easy. Just modifier 95 is all you're going to use. Modifier CS is a new modifier. Actually, it was created a few years ago. It's supposed to be for catastrophes. But they recently announced that they will use it for this public health emergency to get 100% reimbursement for any COVID-19 related service. So if it's related to the diagnosis, screening, or treatment of COVID-19, you use this modifier and it'll get paid 100%. The patients won't be billed a copay, coinsurance, or deductible. This is supposed to ensure that patients get access to the care that they need, and they're not feeling like they shouldn't call in because they're going to have a deductible, and they might not be able to afford that because they might be out of work.
Got it, got it. What about, like, so I know a lot of people in there serving people who might not have, if the patient doesn't have a smartphone, can we still bill a normal E&M code, or do we have to use like the telephone evaluation code?
That's a good question. So there are different codes for different technologies, and I went over on the slides here. If it's an audio only telephone code, there are codes for that. And if it's audio and video, there are codes for that. But I will say this, check with your biggest payers in your area that you deal with, because some insurances have actually said, if it's audio only, bill a low-level E&M visit like 99212 and we'll still pay it. So even though the general guidance is going to be on that chart that I had earlier with regards to the technology that you're using, the insurance always has their own idea on things. So don't just take my word for it. Check your biggest payers in your state, because even in my state, the 3 biggest payers in my state will actually bill, they will pay a low-level E&M service for an audio-only call, which I think is great because a lot of older patients may not have an iPhone. So I think that's a great step.
Got it, got it. So when you say like to check with insurance, most people pretty frustrated, like find it very complex. Is there any tips you can offer the provider? What's the best way to?
If you're a practice manager, typically you can just do a quick report to see who your biggest payers are, and there should be a provider outreach department that you can contact. It's harder for me as a consultant because I'm not a physician's office, so it's harder for me to even get that information. But check their website. Their websites usually have information on that. Especially right now with COVID-19 public health emergency, a lot of insurances have a portion on their website just devoted to that topic. So check there for information.
Great, great. Okay, so we have a question from the audience, Linda. So she's asking, so for telemedicine store and forward coding, what would be the location and place of service be? So for example, if the patient is at an assisted living facility and provider is at the home office.
For the e-visits or the online visits, I think you would use place of service too. But if it's typically a face-to-face service that you would have done, then you use place of service 11. So for the e-visits or the online evaluations, I believe it's place of service 2. But for the telehealth E&M visits, you could use place of service 11, or if it was assisted living, whatever the place of service is for that. I don't have that number memorized, but
okay.
Yep.
Got it. Okay. So I have a question from the audience from Chris. So he's asking, so what is the charging requirements to document like a 5 or 10 minutes medical discussion for the G2012?
Okay, yeah, so for the G2012, which is the brief virtual check-in service, just a note that says that we talked to the patient on this day and briefly what you discussed, and the time would have to be documented.
Got it. If like, for example, in your presentation, you mentioned the CMS update, there's a lot of you can build based on the time in there. How do you track the time? Do you need to use a software that automatic or is more like you just build up?
Yeah, some software that you will use actually will give you the exact time, but a lot of them don't. There is no expectation that providers will have a stopwatch or an absolute, to the second recording of how long the conversation took. I think an estimate is fine as long as it's reasonably close. So for example, if you talk to somebody for 5 minutes and you say, that was about 30 minutes, I'd say like that's way off.
Okay.
But again, you don't have to say it was 33 versus 32 minutes. I mean, that level of granularity is probably not necessary.
I see, but in terms of the getting reimbursement, it's not like you have to use the software to automatically track the time.
No, just whoever did the call can just note somewhere in the documentation for whatever you talked about, call time today, 25 minutes would be fine.
Okay, got it. Okay.
Some people might do a start time and stop time, but there is no definitive requirement as to whether it's a start, stop, or just a total time, as long as it's one of those.
Got it. Okay, got it. Understood. So we have a follow-up question from Chris is, so who qualify as a healthcare professional?
That's a good question. So actually, I used to have a slide on here when I did the longer version that broke down all the different types of providers. And so basically, when it comes to, when CMS says the word physician, they always caveat that by saying, or other qualified healthcare provider, and they usually have a long list of qualified providers. So for a physician, it could be an MD, a DO, NP, PA, certified nurse anesthetist, certified nurse midwives, they have so many different types. If I had to put it to you simply, I'd say if your provider typically bills office visits, put them under the physician category, and if they're not eligible to bill office visits, they're under the non-physician category.
Got it. Okay. So we have a question from Heather asking, so for the place of service code 11 instead of 2, is this only for the time being, or do you expect this will be sort of moving forward?
That's a good question. They did make the change effective immediately and for the duration of the public health emergency. And if I had to guess, I'd say if things go well during this and there's a good reaction to it, I wouldn't be surprised to see them at least extend it to the end of the year and then maybe decide to just keep that change going forward. I think a number of the changes that you're seeing here are out of necessity, but I think a lot of them make sense, and I think that they should keep them. So for example, the time component thing that we talked about earlier, that's already in line with a change they're making next year. So I wouldn't be surprised if they said that change can just stay into effect for the rest of the year as well.
That makes sense in there. In fact, I think this will be a big thing for the whole industry. Otherwise, it's not fair to the providers in there.
Right.
Yeah, we have a question by Carl. So he's asking, so the information you're providing here is applicable to commercial insurance, or is for Medicare only?
Most of the information that I have here is from a combination of two sources, and so it's either from the AMA or from CMS. Anything that you get from the AMA is typically going to be your guidance. So that's what most insurances go for. If CMS has particular guidance, then obviously that they can sort of trump that, because CMS does have the regulatory role in terms of payment policy. And most commercial insurances will defer to CMS. I will always say you still have to check with your biggest commercial payers, because they can sort of make their own rules. Even if CMS has a rule that says they will cover something, if your biggest private payer says, we want you to bill it this way, you probably should listen to them. So the rules that I have on these slides are from either the AMA or CMS.
Got it. Okay. So we have a question from Mike. So does the 95 modifier and the place of service apply to psychotherapists?
Yes. So the psychotherapy services are one of those services that you can qualify for telehealth, and you bill it just the same as you normally would using modifier 95 and the place of service office.
Okay. So again, we have a question for Robin. So do we need 2 modifiers, like so 95 to indicate it's telehealth and the CS to remove cost sharing?
Yes, you could do 2 modifiers in that case.
Okay, got it. So is that the way you recommend by default? You should just always do that, at least for the emergency, given them CMS and say you don't need to do cost sharing.
Right.
Okay. Okay. So we have a question from Mike asking, so can you address, talk about like the insurance company when they're saying they're waiving the copays? So what does that exactly mean?
So for any insurances, and I know a number of them have said this, and CMS is one of them, they're trying to incentivize patients to take advantage of these services. And one of the ways to do that is to waive the cost sharing. So if there's a patient who maybe has a high deductible, or maybe they don't have very good insurance, they're hesitant to actually use any services, even telehealth ones. So to incentivize them, they're waiving the co-pays, co-insurance, or giving the provider's office flexibility to waive the patient's portion. Maybe they'll just accept what the insurance pays and waive the patient portion. So CMS, we talked about that on the slides, but check with your commercial insurance, or even maybe your state governor has made a mandate. And where I live, all of the state governors have made proclamations that the insurances can't bill for patients' co-insurance deductibles for COVID-19 related services.
Got it. Okay. So for a question from Chris asking, how frequent can you claim the G2012 and the G2010 for a single patient?
That's a good question. I'm not sure there is a frequency limitation on the virtual check-ins. If there is, I'm not aware of what that is. I would just tell you to go by the general guidance. As long as it's medically reasonable and necessary, it would be fine. I don't know exactly what the frequency limitation on that would be. But the virtual check-ins are supposed to be happening between visits, between office visits. So the goal of them is to check in with the patient and mitigate the need for them to have to come into your office to get a prescription refill or to just have a follow-up that really is somewhat routine. So the expectation would be there would be a higher frequency of these lower intensity services.
Got it. Okay. So I have a question from Alan. So I think the CS modifier, that's for the CMS. So I think if let's say your private payers, they actually also eliminate the cost sharing, do you also just use the CS modifier as well? Or?
I think that CS modifier, if I understand it correctly, is just going to be on CMS claims. I believe they're the only ones that are going to accept that.
Okay.
The commercial insurances are probably going to do the same thing regardless of if the modifier is on there. I'm not sure it's going to lead to a denial if you put the CS modifier on there, but I just don't think the commercial insurances are going to accept that.
Okay, got it. Okay.
It's a CMS. It's just one of those CMS modifiers.
Okay. So I guess a question from Chris asking, how about the remote patient monitoring there? I know there was at the January, even before the COVID, there's some updates on the code. And last January, there was a set of these people got pretty excited with the remote patient monitoring, the new codes in there. Has that been in the industry? Is that working out well? Do you see a lot of people billing for that?
I haven't seen too much of the remote patient monitoring. There are a number of codes for technology-based remote check-in services over the last couple of years, but the utilization rate has been very low. I think CMS did a study and they found that those codes were used less than 1% of the time.
Okay.
Now, all of a sudden, there's been a big boom in these remote services. So maybe this is the perfect opportunity to test, what works and what doesn't. Maybe it might lead to some changes going forward.
Okay. So the CMS have any insight on why the usage? Because I know a lot of our physicians were very excited to do that because they have huge typical physician offer. They could get upwards several $100,000 of new revenue. Why? I would expect the adoption to be a lot more than 1%. Do you have any insights?
Well, as somebody who's a third-party consultant, I don't really know the logistics of what goes into setting up your practice to do these sorts of service, or the vendors or technologies that you would need to have in place. But I think you're always trying to look at the sort of silver lining. Every dark cloud has a silver lining. Maybe because of this public health emergency, there will be that opportunity to look at if this is something that it's worth investing in the future. And maybe in the future, these telehealth services and practices offering them to patients, regardless of whether they're in a rural area or not, it might be something that comes out of all this as something that's more popular than ever.
Okay, I guess I have maybe for the audience members, it's just if you call Mike, he'll take care of you, then you can really make sure everything from the COVID situation plus the remote patient monitoring. I think for us, we definitely think really excited about it. I think that's going to be pretty transformational to a physician office. So I have a question from Paula asking, how do we build psychotherapy that's done by telephone only?
Just the same as you would in person. So you build the same psychotherapy codes. There's 3 of them. They're time-based. So you just document your psychotherapy by the time spent, and you bill it just the same as you normally would Modifier 95 and the place of service office.
Okay, great. So I have a question from Amanda asking, so Kaiser and the Blue Cross Blue Shield are still requesting the point of service to POC2. Should we double checking, it's just like they haven't updated policy.
I was going to say it's possible that that will change if it hasn't already, and maybe they just haven't published it. Because when CMS said that they want Place of Service 11, it's really tough for commercial insurances to insist that you continue doing it the old way. I mean, are they going to deny it if you bill Place of Service 11, especially if you put the modifier 95? The modifier already tells the insurance it was done over the phone.
Yeah.
So they can't say like, well, hey, you're doing fraud by not using the right Place of Service. The modifier tells them that. So maybe that will change. I can't speak for Kaiser or Blue Cross, but you know, all the guidance that I put on the slides is from either CMS or the AMA. But unfortunately, one of the reasons insurance is so complicated and billing is so complicated is each big insurance kind of makes their own rules. So if they haven't updated it yet, hopefully they will soon.
I see. Okay. So when you get in a case like that, I know like a lot of providers are very frustrated with this whole things, right? So it's almost like they could come, hear a webinar and you're like, looks just amazing there. Practically they do this when they're like, just like, is this, do you have any, like, is this, you just sort of like wait it out a little bit and things settle, or is there like thing that's okay as well?
That's all you can do. You just sort of go with it and do what you can on a day-to-day basis. And hopefully at the end of all this, or even at some point in the middle, is a point where you can catch your breath, figure out what's working and what's not, and just make changes from there.
Okay. Okay. So a question about Rebecca asking, so for the purpose of billing, so she have heard that the provider should use their address, even maybe their home on the 1500 form. Would this, conflict with the enrollment or?
Yeah, I wouldn't do that. The 1500 form should be using the address of your practice that they're, that's going to be on all the credentialing paperwork in terms of where they practice. If you start changing that to their home just because these are services being furnished remotely, that might lead to some problems. So I wouldn't do that unless the insurance is telling you specifically to do that, in which case hopefully that's not happening.
Okay, got it. So we have a lot of audience and asking, so like, what is G2010 and the G2012? Can you explain that a little bit?
So those are the two different Medicare codes for the virtual check-in services. There's two options. G2012 is for the virtual check-in. That's the brief technology-based check-in, 5 minutes or so. It can't be related to an E&M service that was furnished within the last 7 days, and it can't result in the next available appointment face-to-face. So it's, again, the goal is to mitigate the need for an interim E&M service. The G2010 is the same thing, but instead of a telephone call, which is live, it's stored and forward. So maybe the patient records a message or takes a photograph, sends it in using a secure patient portal of some sort, and later in the day or the next day, the provider logs into that portal and reviews the image or listens to the message and then responds back. So if it's live, it's G2012. If it's stored and forward, it's G2010.
Now, can you build them together in a scenario where, let's say that you start with a store and forward, then the provider write some notes in there, then they sort of escalate into a live video visit?
That's a very good question. I'm actually not sure if you can bill both on the same day of service. If you do bill both, I'm not actually sure if that would deny. I haven't checked the National Correct Coding Initiative to see if there's any conflicts between those two.
Okay, got it. Okay. Now, in terms of like the check-in in there, what about like after, let's say you had a video visit in there, then you just want to check in on how the patient's doing, like afterwards, did some routine callback to say now you're still in pain type. Can you get reimbursed for that?
So I would tell you this: if the service is of the same intensity, the amount of resources, the amount of time of a typical office visit, then go ahead and bill it as an office visit. But if it's just a brief check-in, you would do after a service, but it's just a brief, did you get that prescription refilled, or have you had any side effects, or just wanted to follow up to make sure you're okay, I would just document that for good practice, but I don't think that would be separately billable, just like you normally would for an office visit.
Okay. So I have a question from Chris. So I think he's referring to one of your earlier slides, which he says, there's like terms like telehealth, telemedicine, so remote patient monitoring, there's like you're hearing over again, like what, could you just provide some insight between these buzzwords And specifically,
Yeah.
how do you think about how this will impact you when you're coming to like billing?
Right. So both the terms telemedicine and telehealth are broad terms that actually describe an entire category of remote services rendered to a patient using technology. Neither of those terms indicates a specific code or specific type of service, and that's what most people get confused about. So, for example, CMS had a transmittal a few weeks ago where they said they're going to pay for telehealth services regardless of the technology used. And what people heard was telehealth service. What they thought was the particular type of visit that they were thinking of. So they thought, well, that means you can bill E&M services regardless of the technology used, because that's what CMS said. But I told them, if you read what they actually said, they said they're going to broaden access to telehealth services, which is a broad category, not one particular code. So both the terms telemedicine and telehealth mean remote care to patients, but they're both categories, broad categories. The individual codes are on that slide that I had with the chart. Depending on the technology you used, here's the code. So just refer to that for a breakdown of which particular type of telehealth or which particular type of telemedicine code you should be billing.
Okay, got it. Okay. So for question from Chris asking, so if a physician has a physician assistant who does evaluation management service for the patient, now can the PA do the charting and for the purpose of billing?
Yeah, so just like normally, a PA can see a patient in the office and bill an E&M visit. An NP can see a patient in the office and bill an E&M visit. One question that I got recently was, can a PA bill a telehealth visit as incident 2? I don't have a clear answer. I'm pretty sure it would not qualify as incident 2, because part of incident 2 billing for CMS is you have to have direct supervision. And I don't think that being available by phone qualifies. So I don't think that's going to be allowed. But the good news is they can still bill under their own NPI. They can bill under their own information, their own name, just like they normally would for an office visit.
Okay, got it. Okay. So yeah, this might be like a just broaden the scope a little bit. So we've been hearing quite a bit, right now in the past, I'll say like a month or so, there's just like this rush of people doing telemedicine in there. Then recently, there's a bunch of articles, and we also seen this within our customer. People now like sort of pulling back. They've been doing this for a month. Then look at their actually reimbursement. They're taking a huge hit versus what they were doing before in this, like this across the healthcare system. We just seen like over again in this. Now, is it because they just like, first off, is it because they just didn't hear from you and they didn't they made a mistake in their wages? Like, do you have a sense? Like, what I'm asking is like, supposedly they do everything perfectly in this. Like, you have a brick and mortar practice. Now they're like, because of COVID, now they're like 100%. How much money could they make in there? Like,
yeah. As with many things, it's going to depend on how well prepared they were before the crisis hit. Some practices were already, they had software in place, they had contingency plans in place in case there was a hurricane or in case there was a flood or in case the building was destroyed or damaged. They could have either a remote site or they could have remote services. And those practices, when the crisis struck, were already prepared to move people remotely and even offer services remotely. Some had no such plans, and as the crisis was unfolding, they were trying to figure out what services they could use, how to even set them up, get the technology out to everybody. So they're already behind the curve. So that's one thing that people are right now trying to ramp up to use these technologies. The other thing is, now once you have them, do you have the patient infrastructure? Are they aware that they can use these services? Are they using the services? Are you reaching out to patients to let them know they can be calling with these telehealth services? So it's kind of twofold. It's one, are you prepared for it? And second is, are your patients prepared to use it as well?
Okay. But I think I'm asking something slightly different. Assuming, like for example, last like a couple of weeks, right? We're on board and literally like thousands and thousands of physicians, like every single day. We see this across the industry as well. So we feel like they got a technology squared away. Then they've been doing this after a month. They're finding that they look at, if you're like a hospital administrator, you look at, I was getting this much money like the pre-COVID, all of a sudden now I'm getting 20, 30% now what like what, oh, is it like, is it, you know, if like I'm saying, if they actually hired you, right, so like they done it perfectly,
Yeah.
how much should you expect like they can get?
I mean, it's tough to say because it's not as efficient as having an office where patients come in at schedule and they see you and they leave and you see another patient. It's less efficient to do it this way, which is going to lead to less reimbursement. The other thing is insurances, we're getting different information. We're still trying to figure out. So at first we were billing it with one place of service and one modifier. Now we're billing it with another place of service and another modifier. So some claims have been denied. Some claims have been paid, but at a lower rate than they should have been. So those three factors are combining. You know, you have insurances that are paying less. You have confusion about how to bill it. You have patients who maybe it's less efficient. You don't see as many patients in a day over the telehealth as you would during your regular office hours. So those are sort of combining to net a decrease in payment. But hopefully that can be mitigated over time with maybe more efficient scheduling and alleviation of the billing and coding aspect of it.
Got it, got it.
I'm still not sure you're going to get to 100%, but hopefully be better than what's going on now.
Now, Mike, in your consulting service in there, do you have like projects? For example, let's say there's a particular provider, a certain characteristic in there. Then if they were to describe to you like roughly what they did before, do you have a way to come up with a way to great, if you now do telehealth, this is how much money you can make there?
It's difficult to say because I'd have to not only look at that individual provider's billing patterns, I'd have to look at their insurances, I'd have to look at their patient population.
Yeah,
It really is difficult to say because maybe you're a pediatrician in a very well-to-do area with maybe not a lot of complicated issues, and everybody has great insurance, and you know, or maybe you're in an underserved patient with an older population, multiple chronic problems, and you know, so depending on your patient population and your insurances that you typically contract with, it's gonna vary.
Got it. That makes sense.
Yeah.
Okay, I appreciate that. I think this is like pretty much like, at least for us, we're here to like over this or people just get a feeling just like they love telehealth, but they're just like they feel like they're like literally dying in there. They just can't make the numbers work.
I know.
There. So I really appreciate like I think right now we have like this flood of questions. Let me just try to go back to that. I have a question from the Chris asking so how does remote patient monitoring, the CPT code 99457, so different from the brief communication of the G2012 we just sort of talked about?
That's a good question. Chris is asking a lot of questions. I might have to talk with Chris. The remote patient monitoring, I'm not even sure that CMS pays that code. I didn't include it in my slides.
Okay.
All I will tell you, so the virtual check-in is something that Medicare pays. I don't think that the remote patient monitoring is even on the Medicare physician fee schedule. So that's one easy difference is Medicare pays this one. I'm not actually even sure of the other requirements for that.
Got it. Okay. I think Medicare does pay for that. My hunch is you have to be actually get into that specific actually part of the remote patient monitoring program for that.
Okay. What is the code for that?
Yeah. How about maybe we'll look at the details, but they will be posting a lot of this information.
Okay.
So I have a question from Stanley asking. So I guess like, are you saying this is regarding the private payers and the copay in there? So when they say they waive that, does that mean the private insurance will pay the copay portion, or it means like you just don't get it? Okay.
No, the insurance will pay it as if you had already met your deductible or as if you didn't have a coinsurance. Okay. So they'll pay the allowable amount.
Okay. So this is a question from Nancy asking. So for mental health with the insurance company that only cover the 90834, the without pre-authorization. So I guess are they now covering for the 90837?
I don't know. So with the 1 hour, I think 90837 is the 1 hour of psychotherapy. And I know that some insurances will only cover the lower tiers. And unless you have pre-authorization, that might still be the case. I don't know for sure. But if you do have the pre-authorization, you can bill it via telemedicine using the same place of services you normally would do it, just using modifier 95.
Got it. We have a question. This I thought interesting from He Yuan saying, so in terms of like the clarification on the location in there. So I think earlier you mentioned, so if the patient's at home, physician in their office, then you can bill, the location is a physician office. Now,
Right.
what if
Yep.
the physicians also is working from home?
It matters where the service would typically be furnished. So even if the physician's at home, if typically this would be an office visit, bill it as place of service office.
Oh, wow, that's actually very cool. I think
Yeah.
I'm pretty sure like probably 99% or 95% of the people, I think they're getting that wrong in there.
Yeah. So
Got
it's
it.
easy. Just bill it the way you normally would.
Got it. Got it. Okay, that's very, very cool. There.
Yeah.
So really, it's like not where you're physically located,
Yeah.
but
Just
it's
where would it
really
usually be done?
I see.
So if you
Okay.
usually would do that in the office, if it's a psychotherapy appointment, you typically have them come in, go ahead. If you typically would go to the patient's home, or if you typically would go to a nursing home, bill it using that place of service.
Okay, very cool right there. I
Yeah.
think we have got so many people. I guess, Mike, do you have like, you're the expert in this whole industry in there. Do you have like these were like the most frequent mistakes people make? Like what are the people like just getting like to making this like here's what 5 mistake or 10 mistake, all of a sudden they get like a missing a bunch of money.
Oh man. I think it varies depending on different practices, but it depends on if the providers or the coding staff or the billing staff have training. If I go to a practice that has no training at all, typically when I do, I'll go on site with them. I'll do a brief audit of their documentation, their billing, and I'll meet with them and I'll go over my findings. Sometimes they're under billing dramatically, and you'll say, well, who told you to bill it that way? And they'll just say, well, I think I read it in an article a few years ago, but again, it's out of date information that they have no source for, or they're worried because they don't know, they don't want to get in trouble. So they're typically leaving a lot of money on the table, 25, 30% on the table, because they're voluntarily underbilling because they don't know what they're doing. So if you just invest in some training, you'll know what you could be billing, and you can bill it confidently knowing you're not going to get in trouble. The flip side of that is people who don't know what they're doing, and they just bill everything that they can think, everything that they think there's a code for, they bill at the highest amount. And those people, when they get an audit from me, they find out that by correcting, obviously going forward, they're going to be doing it correctly, but they're going to take a lot of risk out of their practice, because if the government doesn't audit or a commercial insurance doesn't audit, they're not just going to take back the money on the claim that they audit. They're going to extrapolate over the period of time and take back tens of thousands of dollars. And I've seen that happen. So the biggest problem, it's not just any one area, it's just lack of training, lack of awareness. It's a good idea as part of your compliance policy to have training at least once a year, so that you know what changes are going into effect in your specialty. And just as sort of a checkup, just like you have your patients come in for a checkup, you should be having a checkup of your billing practices, of your revenue stream cycle, just to make sure that you're not, hemorrhaging money or making mistakes that could cost you a lot in the end.
That makes a lot of sense there. So I have a question for Martha asking, so she's a registered dietitian, that's state license. So the Blue Cross Blue Shield Texas is not allowing the telehealth for like many of her patients. Is there anything that she could do, like any regulations she could cite that can sort of like deal with this?
I believe dietitians were on the list. I actually don't have that slide in this presentation, but on the longer version of this presentation, I believe dietitians were on the list of non-physicians who could furnish telehealth services. So on this slide, where I had the different types of service, depending on the type of technology used, a lot of times there's one range for providers and one for non-providers. I believe that they could use the non-provider codes.
Okay, got it. Okay. Again, this case is where just like, I know we mentioned this a little bit earlier. It's just like again, there's no, you just have to just call the insurance company and tell
Right.
you sort of,
Yeah.
okay, yeah. Yeah, I get that. Unfortunately, this is just a life. There's like, there's no
That's the
way.
unfortunate reality.
Yeah,
Even if sometimes the insurance should be doing it, sometimes they'll still deny it, and they'll come back to me and say, Mike, I thought you said it was okay. And I've had it happen where I have it from the state, I have it from the government, I have it from other insurances, I have it from the AMA, but this one insurance will say, no, we don't do it that way.
okay. In that case, is there anything they could do, or is really just there's not?
You can do what I recommended my customer do, which is go to the state insurance commissioner and say that you have one insurance here who's not doing something that would clearly benefit their patients, clearly benefit them, for no other reason than to just deny, either hope that you would drop it or to deny claims. And it's kind of a pain to do that, but that insurance that I'm thinking of did actually eventually change their ways.
Okay, yeah, but I guess that's just like just feel like one person going against a huge bureaucracy is like
I know that's what it feels like sometimes. Yes, it's unfortunate, but that's the way it goes sometimes. But there is something you can do. Go to the state insurance commissioner.
Got it. Okay. So I have a question for Amanda asking. So, can a provider bill for the collections for the COVID-19 test?
Bill for the actual testing services, the lab.
Yeah,
the lab testing?
actually, yeah, doing the collection.
Yes, they can, and there's new codes for. You have the collection service, and then there's the lab service itself. I don't have them on these slides, but there was an emergency panel put together. The AMA rushed to publish a new CPT code for the lab test. CMS rushed to add that CPT code to the fee schedule, and the WHO put together an emergency assembly to have a new code for suspected COVID-19 exposure and a new code for lab confirmed COVID-19. Again, I don't have them on these slides, but those are all available on the CMS, AMA, and WHO websites.
Got it. Okay. So I have a question for Shannon to say. So I think in your earlier slide you mentioned about I think the annual physical or wellness visit. So that's not qualified for telemed, right? Was that?
Strangely, the Medicare annual wellness visit does qualify for telehealth.
Okay.
But for commercial insurances, the routine physical does not. So a 35-year-old yearly checkup cannot be billed for telehealth. You'd have to reschedule that to a time when they can come in and have a physical. But for Medicare, Medicare actually doesn't cover an annual physical. But a couple of years ago, they actually did start covering something called an annual wellness visit, which is similar, but it includes a number of different things that I guess CMS feels is important for their patient population, including a health risk assessment and list of providers who participate in the patient's care. So because of the nature of it, they actually said it's on the list of things that do qualify for telemedicine.
I got it. Okay, that's interesting. Yeah. So I have a question from Damien asking. So it's the CS modifier. Is that only for Medicare? Does that also apply to Medicaid?
I believe it's going to be Medicare or Medicaid.
Oh, okay. Terrific. So I have a question from Catherine. So for the virtual check-in, the G2012, does it also apply to like clinical psychology or neuropsychology services?
The virtual check-in, I believe, should, but again, that type of service is just a brief 5-minute check-in with the patient between visits. Okay. It's not supposed to replace an office visit. So if you're doing something that would typically be billed as a 99213 or 99214 or 99215, just bill that instead. Mm-hmm. I can't imagine that sort of service happening in 5 minutes or less.
Okay. How about in terms of like right now there's like a lot of activity in the physical therapy space in there. Do you know if Medicare will cover physical therapy?
It's kind of strange because I'm not sure how they would furnish that service using telemedicine, but at the same time they did list, I forget if they listed the codes but not the providers, or they listed those providers but not the codes. In their recent expansion on March 30th, they expanded the amount of services that did qualify. And for whatever reason, they didn't include physical therapy, occupational therapy, or speech therapy. But they didn't give a clear reason why it was not there, which leads me to think maybe it was just omitted, or maybe it will be added later. So we'll see. Stay tuned for that.
Got it. Okay, got it. So we're coming down to the end of our, by the way, first off, apologize that we still have like a lot of questions. I think of all the, the many years we've been doing this, I think you got the most questions ever. You broke a record. We're just literally couldn't keep up. So the clearing demand. I guess as we wrap up is like you taught us so many things. I'm very grateful for teaching us, like teaching me, and so on. Like, if there's like a one big takeaway you want the audience to take away from this, like what would that be?
Just that these services have been around, but they were used less than 1% of the time. And now, because of this public health emergency, they've been thrust into the spotlight. But going forward, I wouldn't be surprised to see this sort of take off. So these services are now more broadly available than ever before. Previously, you had to be in a rural area, and even then you had to travel to a nearby office, which makes no sense. So I wouldn't be surprised to see some of these changes being permanent. Again, that's a lot of times what happens. They say that the necessity is the mother of invention or ingenuity. These codes existed, but nobody used them. All of a sudden, here we're thrust into a situation where we need this, and it's stepped up and filled a void. Again, not perfectly, but it's there. And so when something like that happens, sometimes you see it taking off. So that's the one thing to take away is these codes are more broadly available than ever, and now's the time to take a look at using them, take advantage.
Terrific. Then another question is, so I mean, you're an expert in this industry in there. So what is the one thing that you believe about telehealth that other people do not believe yet?
So what I've thought, and I'm not sure this is going to happen, so maybe I'm going to sound crazy, but I think this is going to be possibly at least one path of sort of the future of healthcare. It's a future option for health, maybe like a pillar of, not replace office visits. I don't want to say that, but I'm just saying there's been a number of different trends. Back in the day, it used to be that you're in your little community, the doctor would go to your house and he would, stop by. But over time, that has faded away, and then it's been the physician stays in his office and you go to him. And because, again, there's more people, I wouldn't be surprised if going forward, this becomes another option of, yes, you go to the office or you just sign up for a virtual visit. And again, so many people have smartphones or laptops or something where they can do this type of service. So the one thing that I believe about telehealth is that going forward, it's going to be possibly the future or one of the paths of healthcare. So we'll see.
Got it. Okay. And the final question is, so you're really thoughtful on this one. So if you have a magic wand, you just wave it, then there's one thing that would change about the U.S. healthcare system. Like, what would be that change?
Just that, and this is something that's not going to be new. I've been looking at this since the 90s at least, or actually probably earlier than that. It's some way to make sure that everybody has access to healthcare, good quality healthcare, not just bare bones. I think that for a long time, there's been different ideas about what that looks like. And I'm not even saying I'm going to put my hat in one ring or the other. I don't care if it's universal coverage. I don't care if it's public option to buy into Medicare or Medicare for all or what it looks like. But there needs to be something that everybody agrees on that makes sure that we don't have so many people who are uninsured or are underinsured. So they're like, hey, look, I have insurance, but then as soon as you need it, you realize you actually have practically no coverage. Or your insurance is tied to your job. And that's been the way it's been here for a long time. And guess what? We have a virus goes around, all the jobs shut down, there goes your insurance. So now what are you going to do? You need insurance more than ever, but because you don't have work because of the virus, now you don't have insurance. So something needs to change so that everyone has access to good quality healthcare, because without it, you have higher costs, you have worse patient outcomes. Nobody's benefiting from that scenario. So there needs to be a bipartisan effort where people don't just, get into their little parties and say, no, we want this, and then say, well, because you want that, I don't want it. We have to agree and listen to each other and come to some kind of consensus on what it's going to look like. But that's, if I could wave my wand and fix it, I would say yes. My wand says everybody has good quality healthcare.
Okay, well, but does that lead to like Medicare for all, or I mean, is that your magic wand? Or?
That's the thing. It's the good thing about magic wands. I don't even have to pick one. I just say them. I don't know. I genuinely don't know, because every single option has its pros and cons. But maybe the wand that I would wave would be over Congress to get them to actually work together. How about that?
That's
so that they can pick something. Maybe no one thing wins all the way. Maybe there's a compromise, but something needs to happen, because right now we come to one conclusion, then 4 years later, the other party says, well, no, we want to undo all that, and we have our own idea. Even now, I can tell you in 4 years, the next party is going to say, undo this. So there needs to be a bipartisan effort where we don't have to worry about things being done and then undone. Something lasting needs to happen.
That makes sense. Mike, thank you so much for teaching us so many amazing insight in that. By the way, for the audience member, Mike is someone I highly recommend. See if you definitely reach out to him. And I think He will teach you so many amazing things. It's just like amazing guy. I have no other guess. Yeah. Then thank you so much, everyone, for joining us. I really appreciate it.
Thank you, everybody. Have a great day.